Good morning, everybody, and welcome to the session. It's quite early in the morning, so like Will said, have your coffee. And we have for you today a very good panel here. Before I let them introduce themselves, like Will said, I'm Chai Jayachandran. I'm a principal healthcare studio leader for Smith Group for their Southern California offices. And during this really unique time, I'm glad we can all join together to discuss some of these issues. So now, if Alicia, you could start by introducing yourselves, we could start with the program.
Sure, thank you, Chai. Good morning, everybody. My name is Alicia Wachtel. I am with Cedars-Sinai. I am an executive director in facilities planning, design, real estate, and construction. Prior to being with Cedars-Sinai, which has been about 2.5 years, I led the healthcare practice for HOK for many, many years, especially for the Los Angeles region. And I had the privilege to work on many replacement hospitals, complex, large. And now I have the adventure of seeing how those buildings that we design really become truly hospitals with patients, with doctors, with nurses. My direct responsibility is on what we call the growth strategy. So I work outside of our main medical center. Cedars-Sinai has affiliated, bought joint venture with 3 or 4 hospitals in the time that I have been there. So it's exciting growth. And also the whole ambulatory strategy of how do we enter into communities and serve those communities to avoid everybody needing to come to the academic medical center and serve our patients where they are. So as you can imagine, COVID has deeply impacted in all aspects of what we do, especially the critical patient care that we need to provide and the patient care that we couldn't provide for a period of time. And I know that we'll talk about that as we move on. So that's my short introduction. For those of you that don't know me and are wondering, where is she from? I was born in Uruguay in South America.
I was born in Canada, in Nova Scotia.
Not yet.
There you go. I'm Brian Langlands, very honored to be on this panel. I'm the East Coast person. I'm all the way over in New York City. I'm with MBBJ, architectural firm, and senior medical planner and principal. Primarily working out of the New York office, but I sort of travel around a bit. Primarily work with academic medical centers and large healthcare systems. The other thing that might be important here is that I'm on the steering committee for the FGI 2022 edition, was involved with the 2018 edition. And I also chair the Beyond Fundamentals, which is an effort of FGI that wants to focus more on what you should do, best practice, than what you shall do or must do with the guidelines. So I'm sort of walking both of those, as we all do as architects and administrators, at looking at what the minimum requirements are, but really what we should be doing. In New York, I think everybody knows it really hit us in New Jersey first and fast. I mean, it did hit the West Coast in Seattle a little earlier, but New York being the center where everybody arrives, it was no surprise that it hit us really hard. I think everybody knows that we were, up to about 30,000 cases, new cases a day. At our high peak point, and we have, up to about 10,000 new cases a day. But in total, we've had over close to 500,000, about 400,000 cases and 30,000 deaths within the state itself. So this was pretty hard, and we were sort of inventing our way as we went along. One of the things that I was involved with, and I personally feel very fortunate that we had a governor who took this seriously from the very beginning, Governor Cuomo, and really helped put together some task force and things like that. And I was on a Greater New York Hospital Association task force that really looked at where we could put patients or provide support outside of the actual authorized hospital systems. So that's something I also worked on. And lastly, I'll say, we're on phase 2 of reopening. We have some unique differences in New York that may be different from some of the other people on this panel. I think most of our work population arrive by public transportation. We don't take cars. It's a huge consideration that we're really concerned about here. And a lot of us are in tall buildings. And I think one of the weak points that we have is the elevator going up and down. So we also here are still wearing face masks when we go outside, 100% of the time. I was just in Columbus, Ohio 2 days ago, and I was surprised that life seemed to be somewhat normal. No face masks, people having dinner, and I've not eaten in a restaurant in over 5 months. So with that, I will hand this over to Jason, I believe.
Thanks, Brian. Appreciate it. Good morning, everybody. My name is Jason Schroer. I'm the practice executive at HKS, and I oversee our health practice. We're 23 total offices, and I believe we've got health care teams in 21 of those offices. So it's my job to kind of work with those teams and serve them in ways in which we can provide very consistent planning and design work for our clients across the globe. I'm located in Dallas, and as you guys are probably all watching the news, Texas right now is a big hot spot. Most major cities in Texas right now are seeing a pretty severe increase in cases. When we first got into this in early March, I believe probably everybody, Brian described it well, we were kind of figuring it out as we go a little bit. And we kind of coined the term internally as our rapid response, and we set up a rapid response team. And we did work on some alternative care sites throughout the country, not in Texas at the time because Texas wasn't really a hot spot. But we did a conversion of a convention center outside of Detroit. We actually converted a prison wing in Maryland, and we've done some other conversion projects specific to health facilities that were either decommissioned or were not operational. We basically went in and helped get them operational. Those were mostly in Oklahoma. So, as we jump into the conversation, I'm excited to kind of talk about, what we're seeing, what we're doing, how we're responding, some lessons that we've learned, and really jump into some of the ideas that are going to come out of this that I think will impact there's no doubt it will impact our industry and the design profession specific to health long term as we move forward. So appreciate being here.
Hi, everybody. My name is Mike Funderburg. I am the Vice President of Operations with Bernard's. We are a large LA County-based general contractor. I lead our healthcare group and have been, involved with hospital construction and all types of healthcare construction in Southern California for the past 20 years. If you were curious where I'm from due to my accent, I come from a very small silver mine town in Elko, Nevada. How interesting is that? I was very flattered to be asked to participate today because our experience here in LA County is ever evolving. As a general contractor, we have been fortunate from a business and employment standpoint to be exempt from stay-home orders. All of our work has been deemed essential in Los Angeles County through the orders of our governor and our local governments. But that imposes an incredible challenge in the safety and well-being of the tradesmen that are working on our job sites. So I'm very much looking forward to sharing my insights as part of our discussion today. Chai?
Thank you, everybody, for the introductions. So before we move to the question session, I wanted to set the premise for today's conversation. Sorry, going to the next slide. excuse me, it's, okay, here. So I just took a snapshot of how the COVID curve is looking geographically across the nation. Right now, we are at around 2.6 million cases all over the states, and the death count is increasing every day. Also, if you look at the curve that kind of started in March, it was like Brian already kind of mentioned, it really hit New York very early on in April. And right now, it's progressed to the East Coast, kind of weaning down on the cases, and the cone happening more in California, Texas, Florida. So with this context, we kind of want to talk to the panelists about what did they experience during these times, what were some of the impacts on health facilities projects and all that. They already kind of started to mention that in their introduction, but with that, I would like to move on to the first question. And maybe, Brian, you could start with that about some of the design impacts that you saw, not only inside the hospital, but outside. And then you mentioned some of the temporary locations that were set up and all that. So if you could expand on that, that would be great.
Sure. I will go a little bit into depth. I mean, what was interesting with New York City is each hospital was mandated by the government and by the governor to increase their bed capacity by a minimum of 50% up to 100%. So right away, each hospital system was very quickly looking for ways to essentially double the amount of beds it has. So they did this by a number of ways, by opening closed wards, by doubling up patients within rooms, by repurposing, PACUs and pre-op areas. And that was one of the ways to do it. Another thing that happened was that I think everybody heard we were supplementing beds by putting, everybody heard about the Javits Convention Center with 1,000 beds. Even there was a tent in Central Park with 65 beds. It made it sound like, very sick patients were going to these places at the ship that came in, Comfort. That really was not the case. What all of these places were, including the hotel rooms, were a way to shed, either to quarantine well COVID patients or to shed well patients, move them out of the hospital to these other locations in order to free up beds on the hospital. So I wanted to be clear that when we were having sort of outposts of beds, that these were not ICU beds. The ICU beds really were contained to where the hospitals were, although they were expanded into acute bed locations and PACU areas and things like that. The Greater New York Hospital Association set up a task force, a group of, and HKS was on it, a group of architects and engineers and construction managers to look at spaces in non-traditional healthcare. We identified over 40 locations, evaluated them. About 10 to 15, we sort of discovered that they could be used for patients. And what happened was none of those were implemented. And the reason they weren't implemented is because there weren't staff and there wasn't equipment. So one thing we're definitely going to have to deal with in the sort of, we're hoping we're not going to have a second wave in New York. We think we probably are. So now we have a sort of inventory of spaces where we could put patients, but we're certainly going to have to focus in on the staffing and equipment shortage issue. Another thing that happened, and I'll get more specifically to Chai's thing about design of hospitals, things like that, is telehealth became a big thing. New York, NYU Langone Hospital, its urgent care virtual visits increased by about 700%, and its non-urgent routine visits increased by over 4,000%. So I think something we're going to be looking at too in the future is to where it level sets with telehealth, but telehealth in many ways where it was a second-class way of seeking healthcare is really now a first-class way. In many ways, people well prefer it. So what we did find that happened, one of the biggest things was that all of the systems were overtaxed from an oxygen use point of view. This was huge. Most systems couldn't handle the number of ventilators that they actually had to hook up, and the flow rates and the requirements for ventilators and the oxygen is huge. And I think something we're really going to have to address, which was a huge problem, sharing ventilators between two patients, which means each patient is getting less than optimum amount of air and oxygen, is what do we do with our sort of physical plants in terms of the oxygen systems that we have. You know, the number of beds were maxed out for ICUs. The other thing that I think we might talk about in this discussion here today is obviously we're able to maximize the number of spaces in the hospital because essentially everything shut down. And how in future can we potentially deal with a pandemic at the same time as maintaining operations? You know, how do we do something like that and not lose the revenue that we all need? Sorry,
I would like to see if Alicia has something to add to it from the hospital side.
Yes, thank you. So you covered a lot, and we all feel for New York. That was traumatizing to you and to all of us. We had a little bit more time and we learned from New York. So what happened immediately is we were also mandated to increase bed capacity. What that means, immediately deploying command centers. For us at Cedars-Sinai, we are an academic medical center. We have a lot of transplant patients, a lot of very sick patients. We also have research, and we also have a teaching function. So research and teaching had to stop. We have 899 licensed beds, so about 900 beds. We had been running at a census of over 900 every single day for the months previous to the pandemic. So you can imagine, to increase bed capacity, we had to stop all those called elective procedures that are really non-life-threatening procedures. They're important. We had to stop them. We were able to lower our census to about 500 patients. That left 400 beds open for the surge that never happened. So that we touch a little bit there on loss of revenue. Cedars-Sinai, half of our patients, or a bit more, are Medicare patients, so underinsured. The private patients immediately stopped coming. So you can see that, and this is going to affect, when Mark speaks later, how do we fund those projects that we all like doing? So immediately the capacity was lowered, and as Brian was describing, we studied how to increase capacity beyond our 900 beds to about 1,300 with the same means that Brian was describing. So I don't need to demo up there. Now, this crisis mode, this is what we saw immediately. Lack of PPE, and everybody saw that. We do have a whole building that's ICU, so we weren't short of ventilators at any time, but we did have to watch those. PPE for staff, critical. And then staff, how do we help those front line providers to be able to work? I mean, their kids are at home, there's no schools, everything is closed, there's no food at home, toilet paper, right? And yet we need these people in the hospital. So immediately we got hotel rooms for our frontline providers. Things like people were changing in the parking lot because they didn't want to take their clothes and themselves home when we didn't know the rate of infection. There was no infrastructure for any of that. The tents for the ED that everybody deployed, we all have seen them definitely here in California, were critical. The issue that we encounter is communication between the tent and the main buildings. So those are things that probably we didn't think. We can think in the future, low voltage communication. Cedars-Sinai has 14,000, 15,000 employees. From a Friday to a Monday, 6,000 were mandated to work from home. So you can see there the other part. We have the clinical providers, and then we have the rest of us all at one time having to find ways to do what we do. On the side of design and construction, amazingly, all our projects continued, and we didn't see huge interruptions of the projects that we had under construction and under design. The industry switched really quickly to the mandates of the state. And besides one case of hysteria from the general contractor, like, all our projects continued. And that's a feat by the industry that I thank you all for being able to do that. Also, the whole industry, the healthcare design and construction industry reached out to us to see how they could help. And we're really thankful for that. We did interventions that are small interventions in the scale of what was happening. We have a program to put plexiglass shields in all our locations. So I don't know how many, thousands and thousands of linear square foot we are installing of this. And we had to open windows into some patient rooms that didn't have windows on their doors to allow for visibility. We were able to fairly easily arrange the negative pressure issues, and all that heavy infrastructure we could work with. And that's a testament to healthcare design that 10 years before was thinking about what happens during an earthquake, what happens during a flood, what happens during disasters. And this is a disaster we didn't necessarily count on at this magnitude, but I think that the design industry had looked at some trends that helped us navigate this. Now, moving forward,
Alicia, you bring up a good point about resiliency and the need for that in design. And what are some of the challenges we face while we try to adopt resiliency? So maybe Jason, you can start with that answer, and Alicia, you can join in.
Sure. Yeah. So I think we need to kind of start from the beginning. And I think one of the lessons learned, and we kind of intuitively already knew this, but really today's hospitals are not designed, for pandemics. And there's reasons for that. Obviously hospitals are very expensive to build, and they're also relatively long lifespan buildings, maximum lifespan of about 50 years. And so it's not easy to start over when you think about our hospital infrastructure. And while we talk about flexibility, we have for decades in terms of how we do that in our designs, one thing that we learned was that while our designs may be flexible, they couldn't be rapidly changed quickly. And I think that's one lesson that we're learning, and some things that we're beginning to look into in terms of how can we design where flexibility can be more rapidly deployed. And the other piece to this is, how do we compartmentalize within the building those hot zones of infectious patients? And the idea of compartmentalization is not new to health in terms of life safety, but we need to really start thinking about that maybe in terms of contagion. And, just you think about a submarine and the way that they're designed in terms of if something happens in one portion of the submarine, you can kind of close it off. And what it does is it maintains safety. You can contain that infectious spread. It allows you to separate non-infectious people and patients. But something that Brian hit on earlier is it allows you to maintain continuity of operations. And I think that's going to be really important as we move forward past COVID-19, is how can we design our facilities to handle crisis like this, but also maintain operations? Because as we all know, for a lot of people, if not most, healthcare was closed. And where our clients have their margins in terms of business continuity, it's in those elective procedures that Alicia talked about. And when those are gone, it really is a big burden and a big stress to our clients. And so if we can design in ways in which we can help maintain operations, that's going to be a huge piece to resilience moving forward.
Jason, in addition to being able to segregate, how do we move people and materials? Distribution within the buildings I think it's the next challenge. I think the industry has conquered quite a lot of the separating units. What we're seeing is, because of cost, we don't double up elevators, right? We don't double up conveying systems. How do you move food, right? How do you clean? Where's soil and dirty? How do you separate? So that's that infrastructure of how things, materials, people move around a facility when you have a contagion, I think it's the next area to conquer design.
Yeah, I agree. And Brian and I were talking about it a little bit yesterday in terms of the idea of flows, in particular to, trying to limit cross-contamination. And is there a way to design facilities in which they may function normally one day, but then the next day they function differently, and that you then really restrict and make sure that you have your flows to where you can reduce the potential for cross-contamination. And that certainly can be dealt with in planning and design. But Alicia, to your point, there is a cost that probably comes with that when it comes to vertical circulation and additional circulation. Those are a lot of the times the biggest things that get squeezed and cut, because you want your designs to be as efficient as possible.
Yeah, I guess in yesterday's discussion, we kind of summarized about identifying elements which are cost, which will impact cost versus those which we could incorporate in a better way so that resiliency is more adopted. I guess that was the point. So now I would like to ask Mike if he could start to talk about some of the current situations at project sites. There's quite a few hospital projects underway. So if you could describe what's going on there.
Yeah, certainly. The experience from our side of the table has been challenging, to say the least. We've been very fortunate from an economic standpoint in LA County, and I use the word fortunate because several of our peers across the country, Boston with Consigli, for example, Tellefson in Houston, and GLY up in Seattle, some of our peer general contractors across the country have had unbelievable challenges associated with hard shutdowns on construction projects, healthcare, and everything else included. Our fortunate circumstance in Southern California is our business has been exempt from any shutdown orders with the state or the county. But that's brought significant challenges on our end for our clients, for our tradesmen specifically. March to me felt like, as a human being, and with all the human beings that install these products and build these wonderful buildings, March was in a state of alarm and confusion. Surfaces that were clean yesterday were suddenly potentially contaminated. The PPE we're all very used to deploying on construction projects by way of safety glasses, hard hats, appropriate footwear, and high visibility vests suddenly weren't enough to keep us safe. Wearing masks while we work, when we do cover our faces in the field, we're wearing respirators, and respirators are expensive and challenging to procure timely. So we were having the same issues on how to actively service our clients and stay on schedule and push our projects forward, while our laborers, our plumbers, our electricians, you name it, all of our tradesmen are, these are family men and women that are concerned about the well-being of their own families. Their children are all suddenly at home, and it created a significant challenge. Supply chain disruption has been minor, has been my view of things, but we're still monitoring these things. A lot of our policies and procedures about working during coronavirus have been incredibly challenging. A lot of our crews work 2 at a time. They're required to be very close together as we're installing overhead MEP installations. We've had to innovate with our subcontracting partners and figure out how to do those things while maintaining social distancing, while maintaining face coverings. We were talking yesterday one of the most incredible challenges, I think, as a contractor right now is the conflict between safety glasses and face coverings. It's been a repeated challenge to keep these face coverings over someone's nose without fogging up your eyewear. So we've been experimenting with face shields, which in some cases aren't strong enough to make it through an entire shift. So those have been some of the real challenges we've been facing. The general attitude amongst our crews, and we have 40 active projects under construction right now that never stopped. The greatest challenge has been the cyclical mood of the team. You know, March was scary. April was a determined month where we learned how we could do our work safely. People began to get tired of the restrictions on their normal work activities in the month of May. People became a little lax, I think, in our policies and procedures, and we started to see COVID cases on our project sites, and have been engaged through our own internal task force in trying to map contact out for when we are presented with a subcontract partner or even one of our own people contracting the virus, and trying to still maintain workflow on our projects while all of that is going on. June had its own flavor, you know, with the horrible events that surrounded the death of George Floyd. Los Angeles County, just as many communities across the nation, appropriately, in my opinion, spoke out about how horrible that was. That had an effect on some of our project sites. We had projects damaged in construction in Santa Monica. That all compounds this effort to, in a determined manner, continue to work during coronavirus. And now, as the Times is reporting this morning, cases are spiking in LA County. So there is a concern about what this next surge, if that is an appropriate term to use, will mean to our work. So there's a lot of anxiety surrounding this in the contracting community right now, where we're all trying to continue to have jobs and continue to provide paychecks to our employees, so they can, you know, keep food on the table and a roof over their house.
Mike, from
Thanks,
the owner's perspective, your anxiety is warranted. Because
Yeah.
you mentioned that a large backlog in Los Angeles County, billions and billions of dollars in construction, right?
Yeah.
We looked at it when we time our projects, when to bid them, how to bid them, who are we competing against, right? And now the tables are turning. So everything that's under construction, we are all committed to continue, but healthcare owners, who were saying yesterday, are very conservative. So as we see these market shifts and we look ahead, we are watching very carefully, okay, if there's not such a shortage of workforce in the market, if major projects are stopping and if commodities are coming down in price, can we get more competitive pricing for our projects that we were about to bid? So what we're seeing is many owners rebidding projects or holding them back, already approved and ready for bid, to see how the market evolves. So that huge backlog, I think, is somehow threatened.
So,
Yeah, Alicia, you bring up a good point. After our conversation yesterday, I did a little research internally. We saw prices hold at pre-pandemic levels clear through April. About 20% of our business is an active competitive bid effort. We are bidding 2 projects today, and our expectation is we're going to see a reduction in cost. There is an absolute interest in securing backlog as general contractors to buoy us through 21 and 22. So I'm hopeful. We'll see how 2 p.m. goes today on a couple of these projects we're bidding, but our expectation is going to be we're going to see prices come down.
Brian,
So,
did you wanna add
yeah. So here in New York, what I've noticed is the larger academic medical centers have projects under construction, as Alicia mentioned, and Mike have continued to move forward. Any other project is actually, they've taken all the projects off and are reevaluating them. And really looking at them to see, look at them critically to see if they are essential projects. And they're, I think, reevaluating them, not in the sense of seeing if they could bid them and you know, be able to do them for a lower cost. I think they're trying to look from a fiscally responsible point of view, because they don't quite know what their income will be, what monies will be coming in, and how healthy their system is going to be going forward. The one thing I have seen is a couple of projects that are under construction, even here in New York City. The clients have asked us to look at the project itself, and I'm going to use this term, look at the design through a COVID lens and see what recommendations we can make from a, you know, minor to quite significant changes to the project that is under construction and some in design, to see if we could make it, at least in this sense, respond better in the future to another COVID-like pandemic. And at some point future in this conversation, I can go into detail as to what specifically we're looking at, but those are some of the things we're seeing here in terms of construction.
Yes, so we've discussed the financial strain on hospitals and kind of talked about how that will impact future projects, maybe even strategic planning and everything that comes with that. So now I would like to refocus a little bit on outpatient facilities and what exactly would be their role moving forward, or what would be some of the strategies that need to be in place to deal with what I'm hearing is a post-COVID surge on elective surgery. So if you guys could decide who wants to go first on that one.
So in New York, what I'm not going to speak about is medical office buildings and driving to a site to go into a sort of shared clinic area, because I think those will be impacted. Waiting rooms, you know, just-in-time arrivals, team stations, you know, will there be more doctors' offices in there with consult things? But I do think the ambulatory surgery within the city itself or within the larger hospital system, we need to figure out a way where business doesn't stop when a pandemic happens. Some of that goes to what Jason was speaking about, and Alicia, about having different flows. You know, how can the population feel comfortable and secure going to a site where there's also patients being treated for pandemics? I know women and families did not feel comfortable going to hospitals giving birth. They did not. We were even looking at ambulatory surgery centers to repurpose them as labor and delivery during this COVID time in order to shed that population off, because there's a high degree of anxiety about that. So I don't have an answer for this. I don't have an answer for how we are going to continue to have what I would call elective or luxury services during a pandemic like this. I mean, I'd be interested to hear from others, but I think it's something we're all going to grapple with, and it's something we're going to need to overcome, because if these pandemics are going to come more frequently, we cannot afford to just shut down business as usual.
Yeah, Brian, I can speak to just a few of the things we're looking at. They're very simple, relatively speaking, in terms of kind of in crisis mode. Does your building behave differently on the ambulatory side? When we talk about flows, you know, one thing that we can learn from the retail industry, we've all been to Home Depot or Lowe's, and there's a designated entrance and a designated exit. And those are mostly for merchandise control, right? But really, if you think about it, it could also be about, you know, if we were to design buildings to have a separate entrance and a separate exit, it might also allow us to begin to think about controlling those flows more effectively. And then the idea of integrating some technology into those buildings in terms of temperature check. You know, you can do that now through special cameras. You see them at the airports already. There are some things that you can do to kind of try to mitigate to the extent possible contamination of your facilities. And then I think just operationally, and Alicia could probably speak to this too, you know, the idea of having visitors or multiple visitors is going to have to be rethought about how that whole experience happens through the healthcare experience. Can you bring a family member or not? And if you can, then there's probably going to need to be some protocols as to whether or not, you know, they're healthy and pre-checks and such. And so there's minor things we're looking at right now. It's hard to take a building that's, you know, designed one way and have it function another way, but there are some, I think, some nuances that we can begin to look at through design and planning that can begin to help mitigate potential contamination. And, you know, we want to create a high safety area.
I agree. I think building wise, those thoughts that you're bringing to the table are implementable and they're valuable. When you think about it as, let's say, a health system like Cedars-Sinai is, there are inpatient components and there's the whole outpatient ambulatory strategy. And to survive as a system in these, you know, decades of very low reimbursement, you need them both, right? So what's happening is reinstating the elective surgeries, which we have been told do not call them elective because a lot of them are not luxury. They are, you know, you have a tumor or, you know, something that needs to be removed, like you have cataract surgery, they need to happen or that patient deteriorates. And we're seeing that deterioration on patients because they're waiting, right? So that I think we can reinstate, as Brian was saying, because the ambulatory surgical centers, if you're a system, you can designate COVID, non-COVID, or you can, you know, segregate your cases. It's the urgent cares, and I'm not talking about MOBs with really, they're clinics. We don't have the typical MOBs anymore, but the urgent cares have been abandoned. There's a lot of telehealth, but urgent care, somebody's sick that's coming in. So those are built on a lot of patient flow traffic, which is not supported. And then all the medical clinics that are now reopened with all the things that you guys are talking about, infection control. Now there's a societal shock. Like, I don't want to go. I'm scared to go. So I was mentioning yesterday, several systems that typically were competitors have come together to reach out to the, you know, population health is our, you know, what we talk about, to tell people it's safe to come back. And as we're telling people that it's safe to come back, we're seeing these crazy volumes again. So we are committed to try to reopen as many of our outpatient clinics to provide population health and telehealth, as Brian, you were saying. I mean, a jump from what would have taken us 5 years to get there happened in like what, 2 months, right? From 20% volume to 70% volume. So
Yeah.
that's something that will have to be considered in design heavily. Yeah.
Yeah. Yeah.
Thank you. So moving on to some more design parts about infection control, and I think we started touching on that a little bit. Also about the adoption of virtual care, both in the inpatient, ED, and outpatient environment. I think we've kind of started to talk about it, but maybe we can discuss in detail a little bit more.
I'll take hospital inpatient design. You know, I've been thinking a lot. There's the obvious from, you know, always making sure that our emergency departments and our PACU and even our pre-op are rooms rather than cubicles or bays, that they're outfitted with the medical gases. I think every med-surg, normal acute room, new construction now is going to have additional gases and emergency power in it, just so we could flex to have greater ICU positions. I think I'll just go quickly down a list. I think patient rooms, one thing is all airborne isolation infection rooms. We're going to start to see a resurgence of proper anti-rooms in front of all of those rooms, which, you know, we were sort of moving away from those and having anti-areas. Every patient room is going to have dedicated PPE outside of it. I think it's going to sound stupid, but I think we're going to be rethinking the patient toilet room. We're going to look at lids on toilets. We're going to look at bedpan washers in every single room. I think, you know, even the staff, if we don't have the proper PPE, I think staff will be issued when they start to be employed a proper respiratory mask. And they're like lead aprons are going to lock these away, and they're going to own these things, and the owner will be responsible for providing filters. I think storage just in time didn't work. It didn't work, and people are going to start to hoard. Just like we got rid of pockets on lab coats and clinical coats because we didn't want people to stuff supplies in them. I think storage is going to start being a big thing again. We're going to have to figure out how to address quite a number of these things. The negative pressure, as Jason mentioned before, you know, we're going to need champions on the owner side to help us with this. 10 years ago, we started designing the NYU Kimmel Pavilion. It opened in 2018. The visionary there with Dr. Phillips, head of epidemiology and infection prevention, and he said, I want to be able to convert any floor to negative pressure, 100% outside air at any time. And when I checked in with him during COVID, he said, we're doing fine. This is exactly what this building was designed for. And that was 10 years ago, increased MERV, HEPA filtration everywhere. So I think those are some of the things we're going to start to see change within hospital design.
Jason or Alicia, any comments on that?
Yeah, I think, you know, Brian hit on just about everything. So there's no doubt that we're going to see probably some legislation come forward. We will probably see an evolution of what Brian mentioned earlier, the FGI guidelines, which most states adopt, you know, in terms of the authority having jurisdiction for licensure. And so the idea of scalability and having designs, you know, pre-prepared to be able to scale for more patient beds is going to be key. The idea of acute adaptable rooms that Brian hit on is going to be, I think, a standard as we move forward. You know, they're probably a little bit of a larger room in some cases. They'll have more gases and they'll have more capacity for emergency power. And they may also have capacity for 2 beds if it's needed. You know, that scalability and the rapid scalability that we've learned about through this is going to be paramount moving forward. And the idea of, you know, positive flow versus negative flow, there's been tremendous amount of discussion and literature on that. You know, the simple fact is that right now, not all patient rooms are created equal. And we need to recognize that and find a way in which we can begin to create a stronger infrastructure to support caring for sicker patients in rooms that, you know, on day 1 may not be doing that, but on day 2, they certainly could do that in the future. And, you know, Alicia, there's a cost that comes with that, right? We talk, you know, in our industry about you can't design church for Easter Sunday. There's got to be a way in which we can find the middle ground and the balance there between cost and flexibility. But I do think most clients now are going to be much more open to these conversations perhaps than they were before, just because of what we're going through now.
I think, you know, in California, we have the most expensive healthcare construction, right? Because of Senate Bill 1953 and earthquake and OSHPD. And so to add another layer to that is going to be difficult. I mean, we already pay more than anybody else per square footage of constructions. That's going to be a good conversation. What I would like to add to what you all brought up is in design, thinking forward, don't forget about a couple of things. Relook at the loading docks. You know, we're going to move all this material, and now it's like we have all this contaminated material, and we try to get our loading docks as small as possible. But I've been thinking Loading docks are going to become critical in situations like this. And the command centers. So I think a lot of the high-level academic medical centers have very fancy command centers now. Most others don't. And it can be on-site or off-site, but without a command center, a multidisciplinary command center, you can't manage this kind of outbreaks, right? So what we've seen, we had emergency command centers, of course, but now everything is on command center. Bed capacity, surge, follow-up, infection control. So a lot of technological uses, a lot of areas where you can have multidisciplinary teams constantly looking at what's happening with patients in the hospital is going to be critical, and that takes some square footage and technology as well.
So I just want to add that the one thing I've been sort of grappling with is when are we going to get to a systems approach? Meaning, when do we look at all the hospital systems and start thinking of them as a giant organism, and that any one building can't be resilient against everything? In New York City, we've unfortunately had bombs, we've had the power blockouts, outages. We've had Irene, Superstorm Sandy. We've had all sorts of things, and now a pandemic. And one thing SUNY Downstate, which is a state hospital here, did was they said, we're only going to be COVID. And they took every COVID patient they possibly could. Now, can a hospital manage to do that on its own? That was a state one. But, do we start talking about all of our organizations together as being a system and saying, for this type of situation, these are the hospitals that are best to respond to it. For another type of situation, these are them. And then how do we share the wealth for the ones who have, are losing income because they've taken on that load? But I think at some point we're going to have to start talking about an approach from that point of view.
Brian, that's truly profound. And I think it might catch up to your thoughts sooner than later, because in situations like we've all had seen through the years, right, that we're doing healthcare design, the mergers and acquisitions, right? Yeah. How bigger systems are buying smaller systems, how the independent hospitals cannot survive, right, because of reimbursement issues. And now we're seeing it, in California, it's impossible for the smaller independent ones now to survive. They don't have the volume, they can't upgrade to seismic compliance, right? So it's a double whammy. Whatever they get from FEMA most likely is not going to be enough. They had to lay off staff. I don't know how they come back. So what could be is that others would buy them, right? And as I was saying, in 2.5 years at Cedars, we either joint ventured, affiliated, or bought 4 other large hospitals, right? So I think it's going to be the survival of the fittest, unfortunately, because there's going to be areas fully underserved. What happens to rural health in that case? And the last item to your point is in California, the California Hospital Association has started looking at systemness or compliance with OSHPD requirements of retrofitting, right? Because some hospitals cannot afford it. So really, is everybody going to be hit by an earthquake at the same time? No. Somebody will be on default and somebody will not. So how do we redistribute? And I think that's opened a conversation to what you're talking about, systemness.
Yeah, that's quite a profound discussion. And so before we move on to the question section, do you guys have any closing comments that you want to end with?
I've got a personal one. Very sadly, my mother fell on April 27th. Elderly, vibrant, healthy, and she broke her hip. She fractured her hip, and she was going to go into surgery on Wednesday, the 29th. Got a phone call saying, we're not going to do surgery. Your mother's in the process of dying. So I immediately rented a car, drove to Nova Scotia, 15 hours, and I made it in time to see my mother, non-COVID related. And they wouldn't let me up. They would not let me up to see my mother. And within the hour or 2 hours, they're debating and this, that, whatever, my mother passed away. And I think I'm shifting the focus here a bit, but I'm thinking we, in this pandemic, we didn't protect our healthcare workers, where many of them died. And thousands, tens of thousands of people died alone, and they died without their loved ones with them. And we know how to protect people, and I think we have to do better. I mean, we can't let the next 100,000 people sort of like think that this is okay. So I think not only do we need to think about future design and what are we going to do, but we have to think about the compassion side. People are in business for healthcare because they care. And I think we need to not lose sight of this compassionate point of view where we are letting our most valued people in the country die alone. And I just want us not to lose sight of the emotional side and toll that this is taking. So that's my hard-hitting sort of closing comment.
Thank you, Brian, for bringing it back to the individual, the person, compassion, and as a community, how we have to prioritize that. Bill, are we ready to pass on to the question and answer session?
Yes. Thank you, Chai. So we'll go into questions and answers here. You can either press the raise your hand button in the under the participant box or type it into the chat feature. And I just want to say thank you to our sponsor, Chu plus Gooding Architects. We're really delighted to have their support for this series. And with that, we're going to go to Luciana, who I believe is all the way over in Brazil. Luciana, are you there?
My neighbor.
I'm here. I want to thank for this discussion. I think this is being, all the design for the future discussions from the AIA has been very helpful to engage with all these professionals and conversations about the theme. And I think all of you, it's funny because I was waiting to make kind of a question comment, but I think Alicia, Brian, I think all of you guys already comment on that. We see that this is a moment, right? I think doctor here in Brazil, she's an infectious disease director from one of the main hospitals here. So I've been in touch with her and we've been talking, not physically, but we've been talking a lot about all those exchanges and in between design and healthcare, right? And compassion, like Brian mentioned. So I think it is a multidisciplinary moment right now that we should engage, right? And I think I was back in LA, I came to Brazil to be close by to my family in March. We saw, right, I'm a USC professor, and we saw all the PPE moments, right? All the practitioners and schools, students designing the equipments to try to support healthcare. But we see that this is a multidisciplinary moment, that space will change, right? Maybe create spaces where people can be close by to their family when they say goodbye, right? Maybe it's more space for psychological help for healthcare, because I see my sister mentioning how mind, right? Now all they are challenged to the healthcare, they are very afraid. The people working in the field is very afraid as well. So they need support. So physically, they need support for equipments, psychological support. So it is a spatial, it is equipment, right? It's people, right? We see there, it's all those fields being challenged right now. And I wonder, not how designers, or how can we support that? How those conversations can be happening constantly, right? And not just, maybe it's an effort of building the 3D equipment, right? Something that we see that, so I'm kind of curious how those dialogues are happening right now, and how can we create that as a constant support, right, among different fields. I think it's this, like I mentioned, it's the designer thinking about space and equipment. It's the healthcare professionals helping us to understand what they need, right? Is the psychological help. So there's so many fields involved, and I wonder how can we make that as a constant conversation so that all those fields can be implemented and enhanced, right? Like, so how and I wonder if those conversations are constantly happening, right? How they're happening right now.
Well, I can tell you that the conversations are definitely happening on the healthcare system, on all the healthcare systems, right? So for us at Cedars, for example, we have daily huddles for all staff with daily notices of what's happening, psychological care, child care, payment continuation. But the point of the emotional support has kicked into high gear because, and I'm getting chills from Brian's, losing your mom, so sorry about that. And I also hear from our nursing staff that this is the hardest thing they've ever had to do, to have a patient dying alone. And they are devastated. These are people that have trained to provide care and compassion, and they feel they cannot because they are like gowned from head to toe, like you can barely see their eyes if they're not fogging up. And that patient is at end of life. So we have a post-traumatic syndrome with our healthcare providers that there's a lot of emphasis in working on, to your point of the continuous conversation and emotional care. And then you add to that the inequality society that we're living on right now. When you add that also to our healthcare provider side, the conversations are truly constant.
So we have a question from Jay. Jay, are you on the phone still? Can you hear us? Jay from Canada?
Yes. Hi. My condolences, Brian. I'm actually sort of asking a question that sort of links almost the human level with the kind of system level, and you've touched upon both ends of the spectrum. I'm thinking about the fact I'm originally from India and I've lived in the United States, in New York specifically, before moving to Canada, and so sort of familiar with three different healthcare systems and the spaces that provide those healthcare systems and the kind of disparities that exist within them. Both at an incredibly human level in terms of people and how they're cared for as individuals, as well as an entire system providing equity-based care, right? So I'm just wondering if this pandemic is going to force the issue in the United States. You know, obviously it's a massively political discussion across the country, but I'm just wondering if you think that you mentioned the FGIs, will they bring in something, is there a device that is not purely political, but are there ways, because for instance, family-centered care has been a topic of discussion for a really long time. And what happens when it's simply pushed out of the picture at a moment of extreme sort of distress, at a place when families are literally being sort of torn apart through whether they can be in or out, part of the care or not part of it, and the anxiety and everything around it. So so that's the sort of individual. And then at a system level, I'm also sort of wondering if this compartmentalizing of healthcare might actually start breaking down enormous hospitals that one encounters, particularly in the larger healthcare systems, so that you actually can create some of the flows you talk about. So you don't have these kind of amoeba type spaces. I've personally done hospitals here in Toronto as well, where you're sort of just glomming on these spaces more and more, and then you're creating even ever more complex kind of material flows, patient flows, staff flows, to the point where it would be near impossible to kind of switch to pandemic mode. Thank you again for your incredible insights.
Yeah, I can take the first one, being on FGI, and someone asked a question in the box. FGI is the Facility Guidelines Institute, and it comes up with new editions every 4 years. Last one was 2018. Next one we're working on right now is 2022. And about 40 of 50 states use and enforce some version of FGI. Unfortunately, I have Texas and California on this call with me, and neither use it, although they do look to it to see what's in there, and then they have their own, although I hear Texas is getting close. Unfortunately, because it's a minimum guideline, it's not going to have spaces like that in it. We've often debated whether it should be a minimum guideline or call it a baseline guideline. I think what's going to happen is this more what I would call compassionate, more multidisciplinary sort of shared care and more thoughtful care is going to have to come from more of the user institutional sort of point of view, and the designers like Jason and myself pushing the Alicias to say, well, you know, people are finding spaces like this as being very, very important, and no, we shouldn't turn them into offices later. We shouldn't call a sort of bereavement room also double it as a lactation room. You know, so I think one thing this has done is this has humbled us, I think, as designers and organizations and even construction managers and builders. And I think we need to remember that it's humbled us and not go back to where we were before, and take it as a sort of like a gauntlet, a challenge to do better. And, you know, if you go online to YouTube and you listen to what Alicia was saying, the nurses and the healthcare workers talking about how this has impacted them, it is unbelievable. So I think there will be change. I'm optimistic. I do have my Canadian optimism that I've never left, hasn't left me. But I don't think you're going to see it, you know, mandated in a guideline.
Yeah, I think too, to the second piece of that question, Jay, to your point, you know, many of our facilities have grown over time in the lump and bump fashion, right? Which means that they're very circuitous. Wayfinding is difficult. The flows can be challenging. And we're already seeing now a move towards master planning and really thinking more about how do we begin to think bigger, and keeping in mind some of the things that you know has come up earlier in terms of on stage, off stage. How do you plan campuses and facilities, you know, to support operations that can separate flows? And so we have many clients already coming back to us to ask for us to reevaluate the big picture through master planning that can help them long-term, right, plan for operationally maintaining the correct flows that may be necessary, in particular during a crisis.
Thank you. So, oh, sorry to cut you off.
That's fine.
A few more questions. We're going to go to Scott Reed, who's been waiting patiently. Scott, thank you. Are you on the call?
We can't hear you, Scott.
He's going to have a provocative question. So
it was an amazing question.
So as we wait for Scott, we'll go to Annie Chu. Annie, you're on the line.
Hi, sorry. I just typed in my question, and thank you very much, everyone. It's been really insightful discussions. I think that my biggest question is kind of more in general, the idea about threshold spaces, which you have referred to as anteroom. In different types of practices for us architects and designers, we're now much more aware of the added functional programming for these spaces, whether it's residential, multifamily, office lobbies, etc. Can you share a little bit of some of the thoughts of the anterooms? Like, what are the requirements now in healthcare? You can cite a specific area, whatever it is, might be clinic or, you know, where outpatient or inpatient areas.
Well, so the only required anteroom in healthcare really is the anteroom associated with a combination airborne infection isolation room and a protective environment room. That's the only anteroom you have to have. anti-rooms for protective environment rooms where people are immunocompromised or for infectious patients are optional. I think, though, people are going to start saying, let's protect our staff better, especially on the airborne infection isolation room, and move more towards proper anti-rooms. We were moving out of them in order to have sort of universal rooms and all the same type, and also space savings. The other anti-room I've been hearing more recently is, what do we do about, because in America, we don't allow to have a negative pressure operating room, right? And in Europe and Asia, there are negative pressure operating rooms. So some ways around that are people are starting to think about having an anti-space, a negative pressure anti-space before entering an operating room. So I think that may come along. The last thing I'll say is, some of the feedback I heard about what happened in this pandemic was that a lot of clinical staff were trying to move the equipment towards the door. The IV poles, the ventilators, the wows almost coming to the threshold of the patient room. So every time they had to turn off an alarm or change the IV, they weren't entering the full room proper. And I think this is going to make us rethink. I mean, maybe it'll start thinking us to go back to decentralized nursing outside of every 2 ICU rooms with the views into the rooms. I'm not necessarily a huge fan of those, but they work perfectly fine. But I think what might happen is we might start thinking about the threshold of the room as being more than just a transient space of in and out. We might be providing more power there, more data there, more data connections and things, where in a situation like this, some of that equipment can migrate closer to the door. And maybe that might help us think more about this transition space between corridor and patient bed, where we might start thinking of it in a different way, because that was happening. These things, I'm not sure if Alicia, you saw that, or Jason, but this stuff was migrating towards the door, so you wouldn't have to go all the way into the patient room every single time fully garbed.
Yeah, and I think that was a lot of that was out of necessity because there wasn't enough PPE, right, to go in a room and leave a room and take your PPE off and put it on. And I totally agree with Brian. And we've had internal discussions about, does the 8-foot corridor become a 10-foot corridor, and can we then rethink that threshold between room and circulation? And then the other piece to the anti-rooms is, what we have found is sometimes an anti-room still isn't enough. You have to really think about flows. And so maintain a one-way flow, and in and out, and in where you don and an out where you doff in a separate area can really begin to be much more effective in containing contagion. So that requires more space. It requires, more unique designs in terms of how caregivers come in and out of rooms, but those are many things that are being thought about right now.
Yeah, the only thing I would like to add is that the way that staff works is a bit different than what we're discussing, depending on the level of acuity of that COVID patient, right? So a very acute patient, ICU 1-on-1 ratio, the nurse is inside the room with that patient. They cannot come in and out, right? That in and out is very difficult to do because of all the drowning. And the communication between the inside nurse and the outside nurse becomes critical. And I'm sure you've all seen like these little write-ups on the glass of the ICU that break your heart. So I think in addition to, is there a transitional space? Is how do we communicate inside and outside, and how deep do people penetrate close to that patient? Where are those thresholds that it's not only an anteroom where you can say, okay, now I'm transitioning from, I don't come into the unit, I stop here. I'm in the unit, but I don't come into the patient room. So it's all those transitions that could be analyzed.
We even had some clients, Alicia, exactly as you spoke, if they had the capability to do it based on their PPE, different colors meant different things.
Yes.
So certain colors could be in the rooms, certain colors couldn't. And that was just a visual reminder of staff for them to be able to work with each other more effectively.
So
Thank you. I think, yeah, thank you. I just want to thank them and say that all their insights actually apply to all practice types, all types of building.
thank you, Annie. And Annie, thank you for sponsoring this series. That's Annie Chu with Chu plus Gooding Architects. We'll go to Scott Reed's question. He typed it in the chat, and maybe this is something that all of you can address, but his question was, what are healthcare systems doing to coordinate with the larger community, such as LA County Care?
So I can give you an easy one, Scott. So the county is in immediate contact with all the healthcare providers, right? So they reach out to us and they tell us what they need rather than us reaching out, and we respond. Cedars-Sinai became a testing site for the county. And that sounds kind of easy, but it's not. So we have tested thousands and thousands of county sent patients per day with set up in a parking structure. And then we had all the logistics of where do people come on to be tested for what, because staff gets tested, patients sent by the county gets tested, pre-procedural patients get tested, and then all that you need to staff. So that's one example, Scott, of how we're working with the county.
I think too, we've had some unique experience. I think we can say, a single hospital design will not meet the needs of every community. And so the idea of listening, right, is so important in the design process, where we have even hosted and taken part into community listening sessions as part of the design process. And I think you can learn so much about the stakeholders, right, in the community, and even facilitate conversations so our clients can even have a better understanding perhaps of some things that maybe they can do more differently or more effectively, or invest in different areas in order for whatever we do in terms of design and planning can respond much more effectively to the community needs. And I think those community listening sessions will become more and more prevalent as part of the design process as we move forward. For much of what we're talking about, plus the idea of inequity and access to care, and helping to facilitate some conversations in design and planning on how we can respond more effectively.
Now, Scott, I appreciate your question. I'll offer a little different perspective, and maybe this builds off of Annie's comment about how design and construction in healthcare can transcend other industries as well. We got a very early call from LA County in the first couple of weeks of March regarding high-risk populations, specifically the homelessness population in LA County. And through our healthcare business unit, we've been actively developing a emergency response project for semi-permanent housing in downtown Los Angeles. The project we're working on right now with NAC Architecture is a significant commitment to address these high-risk populations, and the thought processes feel very healthcare-like when it comes to the progression of the design, our approach to the subcontracting effort, and our approach to the construction effort. So the county was very, very, very quick to act in the current crisis, including getting away from the time-consuming challenges of the Public Works Procurement Code. This project that I'm referencing is exempt through state order on the procurement channels, so we can fast track the delivery of it. And the goal is to potentially add hundreds of single occupancy beds for temporary housing to help lower the transmission risk within that population.
Thank you. So we have a question from Eileen. Eileen, are you able to join us, or you want me to? You have a question about healthcare and hospitality.
Correct. Collaboration between the two. Since we saw a lot of that during the pandemic, and we realized that a lot of the healthcare environments as of lately, they do tend to be upscale. And I was just wondering, I always thought about that, it's like, why isn't there not a collaboration between hospitality and healthcare?
Well, there is a collaboration, right, Eileen? I mean, you might have seen or not, systems that patients get discharged to a hotel where a nurse can go and take care of them. Hogue has been doing that for a long time. Now, under the pandemic, a lot of hotels are empty. And where Cedars-Sinai is, which is Beverly Hills, West Hollywood, there's a lot of hotels. They immediately reached out to us and offered very, very reduced rates that we used for our staff that cannot go home, at least during the height of the initial height of the pandemic, because they don't want to infect their families or loved others, or that just want to take a nap and shower. So the hospitality community has reached out to us, and we have taken advantage of that as well. Those are two examples that come to mind.
Yeah, and I would say, at HKS, we have a very robust hospitality practice. And what it's done for us is it's provided opportunity to discuss more collaboration internally, right? First between health and hospitality. And one way it manifests itself for us was, we did early studies on building conversions, and certain hotels certainly could support a conversion to patient care of some sort more easily than maybe some of the other building type counterparts. And so the idea of discussing the similarities between the two in terms of planning and programming and then operations was really interesting. And I think one lesson learned coming out of this is our emergency management plan will probably be a little different for the next one, and that we may have some pre-plans already, ready to go, and whether we convert a convention center or a hotel or whatever that might be much more quickly than we could in this crisis, because we were kind of thinking as we go. The other thing that is really interesting is if you think about a hospitality client, they're there for the experience. And safety was always in that experience, but it was probably low. Now we're seeing that the idea of going to a hotel and being safe is at the top. And so we're having to kind of rethink, what does that look like? Are we specifying the right materials that are cleanable in hotels now? Are we, how can we work with our operators to create cleaning plans that more effectively can be observed by hospitality, clients? And so there's certainly now an overlap between the two that I think will remain. And as we rethink, even some design for hotels and resorts.
Do you see anything like in terms of outpatient care, investments, collaboration in that way?
I'll let Alicia hit on that. We certainly have touched on the idea of destination healthcare, right? Where
correct.
It's more of those elective type procedures that may happen where you go somewhere and it's about the experience. We haven't seen a huge overlap yet specific to North America on what that might look like for outpatient care, other than what Alicia has touched on in terms of a place for people to go post-procedure and or a place for staff to find respite in this crisis.
And I think in Asia it's more prevalent than here, but the executive health and international health relies also on the hospitality industry, because you bring people for a short dedicated destination type of care, and they don't need to stay in the hospital. So they're really outpatient, having battery of tests, but it's a small sector that we're seeing on the overlap.
Mm-hmm.
We have time for one last question from Francesco Galla. Are you on the call? And then we'll do closing remarks with Chai and everyone.
Hi, yes, I'm here. Okay, I'm gonna try to make this as short as possible. First of all, thank you, Brian, for bringing out the concept of compassion and this idea of systems collaboration. A similar conversation came up during a previous AIA talk as we were looking at graphs showing the availability of ICU beds per state. The graph showed clearly that states like California and Oregon and Washington and many others had a great availability of beds, while others in red showed very little availability, and most likely those states were destined to have an issue during the pandemic. That chart almost suggested the need for collaboration of systems. Now, the obvious question is, how do you do that in a country where healthcare systems are technically rivals, right? Now, Alicia suggested a possible solution to that, which is like the bigger fish buys the little fish, eats the little fish. But I was wondering, all that made me wonder if anybody has seen any study, or either current or future, about the impact and the effectiveness of socialized medicine, the S word, in fighting a pandemic versus private medicine. And, or if I mean, this is not a question for, I guess it's a question for everybody. What are your thoughts about the issue? I mean, I'm thinking about New Zealand and Norway, and I mean, even China. The pandemic is still going on, so I don't think we can yet compare the approach and the effectiveness. But yeah, again, has anybody heard, or do you have any idea or opinion in the matter?
The thing that I'm thinking is that, we always say you don't, and I think we talked about this yesterday, somebody else said it, so I won't take credit for it, but that you don't build the church for Easter Sunday. And I think we're going to have to start building the church for Easter Sunday. This has shown us that when we don't have enough beds, we have a huge problem. So, we keep looking at all of these trends and advisory boards and SG2 and how many beds we need where, and we don't need more beds, but we need more beds in the south and less in the north. And I think some of that is going to be thrown out the window because you can't predict how many beds you need in a pandemic. So I think I'm not answering your question, but I think there is going to have to be some rethinking about how we figure out what our need is going to be going forward with the number of beds.
Yeah, it's of course, coming from Francesco, a provocative question.
Oh, do we know Francesco?
We know Francesco.
Okay.
Very talented healthcare architect. I think, Brian, what you're getting at in answering is the answer doesn't come from the healthcare construction industry, right? In the countries that they control it better, that they happen to have socialized medicine, it was also they closed the valve that sends people to the hospitals, right? So it's the chicken and the egg. Do we build more capacity, or we make sure that we have the systems in place to not propagate the pandemic? And then it becomes political, so I'm going to stop right there.
Good idea.
Chai, I'm going to give it back to you to sort of do closing remarks with everyone. Thank you.
Yeah, I just wanted to add, this panel came together very quickly, and I really appreciate this rich discussion. I think these are the kind of conversations that AIA allows us to have. It's a platform where facilities and designers and from the construction side, we can all come together and think beyond our boundaries of who we work for and what we do, and actually think for the better good. So I'm really thankful to all of you. Any additional comments you need to make? I think the audience really enjoyed it. And thank you, Will, for all your help with getting this done. So if you have any final comments, this is your time.
Hey, Chai, this is Jason. I just, real quick, I mean, it's a recap. I think, what we've kind of categorized into three things, and some of the things we're looking at as a firm with our clients is, it's just a repeat of kind of a recap of what we talked about, but hospitals must be designed to change far more rapidly than ever previously conceived. And we need to really think about how that works. And then, as we conceive new designs, we must have pandemic preparedness, from the onset, the idea of flexibility, scalability, compartmentalization. And then what's going to be critically important, I think, is that, that we've got to be able to find a way to maintain normal services, to reduce the perception that healthcare is closed during a crisis like this. And that's going to be important as we find solutions with our clients to figure that out.
Yeah, Chai, I'll chime in. Thank you for the opportunity to talk with everybody. From our perspective, this has been a humbling experience, I think, and I think we all need to learn from it and improve upon it. As a father of 6 young children, I have to hold on to hope and belief that we can do better, so we're not facing the kinds of circumstances that Brian's sharing quite openly and describing to us. So thank you all. I appreciate the time today.
Yeah, I mean, I just think, as we all do, this is an opportunity, and we need to embrace that. And I hate saying learn from it, but we need to embrace that, and we need to really take this as an opportunity to think about the way we do things, and how we can potentially do them better.